Hello and welcome to my session on post-thyroidectomy care. My name is Julia McGovern. I'm a core surgical trainee currently working in North Tees Hospital. This session will take about 20 minutes. It'll be sent out by email, so watch it at your own leisure, and please send any feedback back that you might have via email as well. So I'll crack on and share my screen. So what you should now be able to see is my PowerPoint on the left-hand side and the Essential Anatomy app on the right-hand side. The structure of the talk is going to be an initial part of basic anatomy, and the reason why this is important is it'll give you the context to understand the post-thyroidectomy emergencies, why they occur, and how you can help to resolve them. I'm also going to look at briefly parathyroid glands and the calcium and their role in calcium homeostasis. And again, this fits into the potential risks of a thyroid operation. Head and neck anatomy. It's a bit of a heart sink even for advanced surgical trainees because it is complicated and there's a lot to understand. I'm sure any of you are more than capable of identifying the thyroid gland sitting in the middle of the neck. But what I want to do is talk through the stages of a thyroidectomy in basic terms and the structures encountered. So whenever you're intervening potentially in future, you'll understand what's gone on and what you could potentially be getting yourself into. So I'm going to move on to my anatomy app here and answer the question, where is the thyroid gland located? So with the neck, we tend to, in anatomical terms, separate it into an anterior and a posterior triangle. To draw the anterior triangle, we go from the inferior border of the mandible, down the midline, and up the anterior border of the sternocleidomastoid muscle. If you did this on the other side as well, you would have your thyroid gland sitting in the lower half of the anterior triangle. To then move on to the incision that's used in most thyroidectomy and parathyroidectomy surgeries, you will see a horizontal incision, approximately 2 finger breadths superior to the thyroid notch, or the sternal notch rather, sorry. And you'll see a transverse incision, approximately 6 centimeters long. When you actually see a patient on the ward after a thyroidectomy, the incision will look like a very thin straight line because all of the stitches are on the inside. So to go through the layers that we go through in a thyroidectomy, which is more important in relation to how we close after the operation, we first of all get rid of the skin. And then after we remove the skin or cut through the skin, what you will see is subcutaneous fat. And then you'll see this very thin layer, which is a muscle called the platysma. This is something to the untrained eye is actually very difficult to see because contrary to how it looks in this diagram, it's actually a very thin sheet that barely looks like a muscle at all. But it's important to know about because exactly like the skin, the platysma is closed in a horizontal fashion with interrupted stitches. Once we get rid of the platysma, what we come to are the strap muscles. Now, I briefly just wanted to show you the sternocleidomastoid because this was our lateral border of our anterior triangle. But more importantly, once you've dissected down, you'll come to what we refer to as the strap muscles of the neck. This anterior jugular vein will either be sacrificed or carefully avoided. And then you will get to your 2 set of strap muscles that are relevant to thyroid surgery. In front, we have sternohyoid, and just posterior and lateral, we have sternothyroid. These muscles are not cut during the operation, but they are laterally retracted so that we can access the thyroid gland. Once I've gotten rid of these, you'll be able to see the thyroid gland itself. Now, the thyroid gland sits in the middle of the neck, not displayed here, but it runs in front of the trachea. And the other structures to be aware of are immediately posterior to the thyroid gland. If I hide it, you'll see the parathyroid glands. Now, they're quite a generous size in this anatomical display, because in reality they can be as small as a grain of rice, and they're usually embedded in some fascia and fat, so they can be quite hard to identify and quite easy to damage. Again, what you'll see is the trachea, which, if we put the thyroid gland back in place, is immediately posterior. And once the thyroid is removed, there's nothing else getting in the way of something or anything disrupting and compressing the trachea. If I get sternocleidomastoid out of the way, we can look at some of the more important vessels and nerves of the neck, starting with the carotid sheath, which is surrounding these three structures. We have the common carotid, we have the internal jugular vein, and we have the vagus nerve. And if I'm just able to zoom in on the vagus nerve itself, a very important nerve in relation to thyroid surgery is this branch here called the recurrent laryngeal nerve. Now, we have a recurrent laryngeal nerve on both sides, and both run up past the inferior pole of the thyroid and supply the intrinsic muscles of the larynx. Now, the intrinsic muscles of the larynx are important because they move the vocal cords and therefore help us to speak. So if this nerve is damaged during thyroid operation, a patient can have hoarseness of the voice. Now, it's difficult to show you the course of the recurrent laryngeal nerve because on the right-hand side, as you can just about see, it hooks under the subclavian artery, but on the left-hand side, it hooks under the arch of the aorta. That's why it gets the name recurrent. With any operation, you need to know the blood supply of the organ that you're dealing with. And with the thyroid, you have a superior thyroid artery. If I can just get it here, it's small in this specimen. Superior thyroid artery coming in there from the external carotid. And we've got the inferior thyroid artery, which comes in, as Mr. Dordia has taught me, lateral rather than in under the inferior pole from the thyrocervical trunk. So we've gone through these structures, the thyroid arteries, which are most likely going to be done and dusted after the operation, the recurrent laryngeal nerve, which should be there and should not be disrupted, the parathyroid glands, which should be preserved but can be disrupted, and then the big blood vessels and nerves of the neck. And one I haven't mentioned yet, which I don't know about you, but I always think when people say get them in the jugular, where is exactly the jugular vein? And this is the external jugular vein here, which runs much more superficially. And when you think that your incision is more anterior and less laterally, you shouldn't really be too bothered about the external jugular at all. So that was my whistle-stop tour of neck anatomy. I'm just going to touch now on the parathyroid glands again and their role in calcium levels in the blood. So the parathyroid glands secrete parathyroid hormone. This acts on multiple parts of the body, including the bone, the kidneys, and the small intestine. And the parathyroid hormone, the final result is that it increases calcium levels in the blood. So when your calcium levels are low, your parathyroid glands will kick into action, produce some more parathyroid hormone, and will increase your serum calcium levels. So when we think about the risks of thyroidectomy, hypocalcemia is a very real and reasonably commonly occurring complication because of the disruption to the parathyroid glands. When I go through my risks of thyroidectomy, as you can see or have seen in my previous demonstration, the trachea is in very close proximity to the operating site, and you can get immediate post-op laryngospasm due to the proximity of the larynx and trachea to where you've been operating. This isn't something that the ward doctors and nurse practitioners should come across, because hopefully it should be happening reasonably rapidly after the operation, and the patient will eventually need, most likely, to be intubated. So let's hope that happens in recovery. Hypocalcemia, you need to know about, you need to know how to identify and how to treat. Recurrent laryngeal nerve injury is important to know about, but not something that you will be getting involved in. Post-op hematoma, we're going to talk about now in more detail. and then the generics of any operation, wound infection, scarring and pain are important risks to be aware of. So, talking more about post-op hypocalcemia, the British Association of Endocrine and Thyroid Surgeons have this flowchart on their website. They want you to check calcium levels 12 hours post-operatively, and if a patient's hypocalcemic, treat them orally if mild, or with IV solutions of calcium gluconate at this dose if severe or symptomatic. It's important to know about calcium gluconate. You don't have to know the dose off by heart. You should have an idea, but you can always check the Trust intranet and electrolyte disturbance guidelines in your hospitals if you're not sure. Now, moving on to post-operative hematoma. This is a topic that will rarely come into your practice, but if it does happen, it could be life-threatening, so it's important to know about. A team in Oxford have come up with this acronym SCOOP, which stands for the stages involved in releasing a neck hematoma. What I'm going to do is I'm going to show you their video, which goes through opening the layers after a thyroid surgery, which is something you should only be doing in an absolute airway emergency. I want to start by talking about, what I'll do is I'll show you the video and then we'll talk a bit more about it afterwards. Okay, just bear with me. So you can see here that he's removing the steri strips. You can see the transverse incision. First of all, the subcuticular skin sutures, using scissors or a scalpel. Pull those open. You're probably through the platysma at that stage as well. And then, most important to remember, the strap muscles are closed vertically, so they need to be opened vertically. Now you can see the trachea, which is the most likely place where our hematoma will be collecting. And then they show their flowchart, which is something you can access as well online and have a look at in more detail. Okay, let's get back to the presentation. Don't know what that was. All right, so when are you actually going to do this? I think that there's a hematoma in about 1% of all thyroidectomy operations, and not all of those are going to cause airway compromise. If you're on the ward and somebody has just had a thyroidectomy, the things that you want to look for are not necessarily neck swelling, not necessarily I've got a tight neck or I've got pain, but the one thing that you should be acting on is stridor. So if a patient has a neck hematoma, it's not necessarily the blood collecting itself that's compressing the trachea. It's that the collection of blood is causing edema, it's causing poor venous drainage, poor lymphatic drainage, and it's the airway edema that's going to cause airway compromise and potential respiratory distress. So if you have a patient who's post-operative, who has stridor, low sats and respiratory distress, the first thing that you need to do is put out a crash call. You don't want to go get the phone and sit on the phone yourself making the call. You want to hit the emergency buzzer. You want to get anybody, like a nurse, any healthcare professional, and say, put out a crash call. That's the first thing that you need to do, because you'll never be able to deal with this on your own. The second thing that you need to do then is your ABC management of an acutely unwell person. You've got someone sitting in front of you who cannot breathe, who has stridor, who has low sats. You may have put some oxygen on them, it's not working, what are you going to do? This is an airway emergency, and within 20 minutes of somebody developing stridor, most likely result is respiratory arrest. And there's no guarantee that your crash team are going to get there and help you. There's no guarantee that your patient is going to survive the 20 minutes that I've mentioned. It could be much sooner that they arrest. So a good maneuver that's not complicated, although it is terrifying on paper, is to open the wound. So we mentioned underneath the skin, you're going to have a continuous string of monocryl suture. If you get a finger in there, if you get a knife in there, carefully. If you get scissors in there, a suture cutter, please put the instrument inside the initial part of the neck and open the skin. Once you've done that, you'll have your platysma, which I mentioned, the thin sheet of muscle, and that will have interrupted sutures in it. Again, cut through them, pull them open. They're not going to be strong, they're only going to be thin. After that, very important to remember, the strap muscles are closed vertically. So you need to get an instrument and cut your sutures, or get a finger in the hole at the middle and rip those open. After that, you'll be able to see your trachea and most likely the collection of blood in front. Clear it out with a finger, clear it out with some saline, clear it out with suction, whatever you have access to. This again is from, this PowerPoint slide is from the British Association of Thyroid and Endocrine Surgeons. They talk about neck swelling, they talk about respiratory distress, giving oxygen, maybe giving hydrocortisone and nebulized adrenaline. I do think that if you truly have a patient who's in extremis, who has stridor, like this is the sort of situation that we're talking about, by the time your nurse has managed to get to the drug room and get these medications, you might have missed your opportunity. So what I would say is only in absolute worst case scenario should you be doing this, but it's important to know you should be opening the neck and evacuating the hematoma, and you have to open right down to the trachea. That's pretty much it. I mean, the likelihood of any of you guys being in this position is low, but the reality is patients do die from post-operative hematomas after thyroidectomy surgery. We have had a similar case in North Tees, and there have been other cases in the Northeast, so it does happen and it's important to know about. Basic anatomy and physiology, whether you like it or not, are the basis of all medicine. And I think once you understand anatomy, you're much more comfortable in intervening when you know what's underneath. In an emergency, you should feel empowered to intervene. You are the front liners on the wards, you are the front liners looking after our post-operative patients, and everybody appreciates the work that you do. It's not just about discharge summaries and medications. We know that when there's a true emergency, it's often the ward-based healthcare professionals who are the first on the scene. Calling for help is always the right answer, but it's also about knowing what you can do while help is on the way. And I hope that you've taken something from this talk, and thank you very much for listening. Here are my references, and that's it for today. All right, bye.